Your doctor prescribed that cholesterol pill. You trusted them. You filled it. You've been taking it for years. And the entire foundation that prescription was built on just changed. In January 2026, the American College of Cardiology quietly released updated cardiovascular guidelines. And buried inside that document is something millions of seniors were never called about, never emailed about, never told at their last appointment. The guidelines now explicitly recommend individual reassessment for adults over 60 who have never had a heart attack or stroke, before simply continuing statin therapy year after year on autopilot. That means if you're taking atorvastatin, rosuvastatin, or simvastatin right now, and you've never had a cardiovascular event, your doctor may be operating on outdated math.
And that outdated math is costing you more than you realize in muscle strength, in energy, possibly in memory, and in side effects your physician has been calling just aging. I'm Dr. Anthony Miles. This channel exists to give you research that's actually designed for people over 60, not filtered through pharmaceutical marketing or medical inertia. Subscribe now so you don't miss what's coming over the next several weeks, because the content we're releasing is going to change how you look at your entire medication list. Here's the answer straight. For adults who have never had a heart attack or stroke, what doctors call primary prevention, the evidence supporting lifelong statin therapy is genuinely weak. And for adults over 75 specifically, the updated 2026 framework calls for reassessment, not automatic refills. That is not fringe medicine. That is the American College of Cardiology saying the old default no longer holds. Here's the science behind why, and it matters that you understand this. Statins block an enzyme in your liver called HMG-CoA reductase. Block that enzyme, LDL goes down. The number looks cleaner on paper. In patients who have already suffered a heart attack or stroke, this benefit is real and the research behind it is solid. But for patients who have never had an event, the math works differently, and it changes further the older you get. A major analysis published in JAMA Internal Medicine examined statin outcomes specifically in adults over 75 with no prior cardiovascular disease. The finding that stopped cardiologists cold was this: the absolute risk reduction was far smaller than the relative risk numbers that pharmaceutical summaries highlight. The number needed to treat, meaning how many patients must take the drug for years to prevent even one cardiovascular event, was high enough that for many older adults, the medication's side effect profile simply outweighs the benefit. And that side effect profile is where this gets serious. Statins deplete your body's natural production of coenzyme Q10. This is basic biochemistry, not alternative medicine. The same metabolic pathway statins block to lower cholesterol is the pathway your body uses to produce CoQ10. When levels fall, a condition called statin-induced myopathy develops. In seniors, it shows up as unexplained leg weakness, muscle aches from nowhere, difficulty climbing stairs, and a creeping fatigue that doctors routinely dismiss as simply getting older. Because it looks exactly like getting older, unless you know what to look for. Margaret was 71. She had been on atorvastatin for 8 years. Her cholesterol numbers were immaculate, but for 2 years, she had been weakening. Her neighborhood walk disappeared. Stairs became an event. 3 doctors told her this was age. Her daughter brought her in furious. When we reviewed her complete picture, CoQ10 levels, muscle enzyme markers, and her actual calculated 10-year cardiovascular risk, given that she had no prior events and no diabetes, the conclusion was stark. Her risk-benefit calculation had quietly flipped years earlier, and nobody had looked. Under proper medical supervision, she went through a structured reassessment. 6 months later, she was walking 2 miles every morning. Not from a new drug, from finally asking the right question. Now hear me clearly on this. Do not stop your statin on your own. I will say that once more. Do not stop without medical supervision. If you have already had a heart attack or stroke, you are in the secondary prevention category and statins remain well supported for you. What I'm giving you today is information to bring into your doctor's office, not a reason to throw pills in the trash on your way home. Are you currently on a statin? Comment below with yes or no, and tell me whether you've ever had a cardiovascular event. It matters. It helps us understand exactly what our community is facing. Here is where 2026 guidance diverges sharply from the old model. The updated framework moves away from treating LDL as the single number that determines everything. Research from Johns Hopkins, published in the European Heart Journal, demonstrated that the same LDL number carries dramatically different cardiovascular risk depending on your systemic inflammation levels, your insulin sensitivity, and your metabolic health. A person with naturally higher cholesterol and low inflammation may carry far less cardiac risk than someone with a perfectly controlled LDL sitting on top of unaddressed metabolic dysfunction. This is why people with textbook cholesterol numbers still have heart attacks. The number was never the complete story. The 2026 framework is finally catching up to what the biology was saying all along. But here's what shocked me most when I went deep into the updated guidance. The lifestyle interventions now being validated at clinical levels rival what statins were delivering for primary prevention patients, and without a single one of the side effects. Soluble fiber at 10 to 15 grams daily, oat bran, psyllium husk, ground flaxseed, legumes. A meta-analysis in the American Journal of Clinical Nutrition documented 7 to 10% LDL reductions through bile acid sequestration, a mechanism completely independent of statins, no muscle involvement, no CoQ10 depletion. Plant sterols and stanols at 2 grams per day. The National Lipid Association confirms consistent LDL reductions of 8 to 10%. Look for phytosterols or plant stanols on the label. Available at any CVS, Walgreens, or on Amazon, search plant sterol supplement. Omega-3 fatty acids, but not at the dose most people are taking. One standard fish oil capsule with 300 milligrams of EPA and DHA does nothing clinically meaningful. The Reduce It trial used 4 grams of EPA daily and showed a 25% reduction in major cardiovascular events. You need 2,000 to 4,000 milligrams of combined EPA and DHA. Talk to your doctor about your specific target, but understand that one soft gel per day is nutritional, not therapeutic. Address your CRP level. C-reactive protein, systemic inflammation, is now understood to predict cardiovascular events in many older adults more reliably than cholesterol alone. Curcumin at 500 to 1,000 milligrams daily in a high bioavailability form has shown statistically significant CRP reductions in multiple randomized trials. Combine it with 30 minutes of moderate walking 5 days per week, and measurable inflammatory change happens within 8 to 12 weeks. Before I give you the exact action steps, I want to tell you about something statins do that almost nobody openly discusses. Frank was 68. 5 years on rosuvastatin. His wife noticed it before he did. Words disappearing mid-sentence, names vanishing, a fog accumulating slowly. Cognitive effects from statin therapy appear in the medical literature with a documented mechanism: reduced cholesterol availability in the brain's neuronal membranes. Cholesterol is not the enemy in your brain. It is structural material. When we ran Frank's current 10-year cardiovascular risk using the updated pooled cohort equations, the medication was delivering minimal absolute benefit against a real cognitive cost. His mental clarity improved substantially within 3 months of a supervised transition to the protocol I just outlined. This is why this conversation needs to happen in your doctor's office now, not next year, now. Here is exactly what you do starting this week. Request a complete cardiovascular risk panel, not just a lipid panel. Ask specifically for a CRP level, a fasting insulin level, and an LPA measurement. Lipoprotein(a) is a genetic cholesterol marker your standard panel completely misses, and it significantly changes risk calculations for many seniors. Ask your doctor this exact question at your next appointment. Based on the 2026 ACC guidelines, what is my absolute risk reduction from continuing this medication, and when was my risk-benefit calculation last reassessed? Push for a number. If your doctor cannot give you one, that reassessment has never happened. If you are in primary prevention and your doctor agrees a reassessment is appropriate, ask specifically about a structured deprescribing protocol, a gradual monitored reduction with regular testing and clear benchmarks. Begin the lifestyle protocol immediately, regardless of what happens with your medication: soluble fiber, plant sterols, therapeutic omega-3s, inflammation management. These interventions carry independent cardiovascular benefit, and they stack. If you stay on your statin during this process, add 300 milligrams of ubiquinol daily. That is ubiquinol, the active, absorbable form of CoQ10. It directly addresses the depletion your medication is creating. The old model was simple. Your number was high, you got a pill, the conversation ended. The new model requires an actual conversation, one that most seniors have never had. Your job now is to walk into that appointment prepared to have it. Comment one of these below. Comment reassessing if you are bringing this to your doctor. Comment your current statin name if you want us to do a deeper video on that specific medication. Or comment no statin and tell me how you're managing your cardiovascular health. I genuinely want to hear what is working for people in this community. If this gave you something real and actionable, subscribe right now. Next week, we are covering the specific blood tests that predict cardiovascular risk more accurately than any standard cholesterol panel, and most doctors are not ordering them. I'm Dr. Anthony Miles. You deserve evidence that works for your body at your age. That's the only reason this channel exists.